lift their leg and tap their foot on the step. So imagine having like an 8-inch step and just having them toe tap onto it with their surgical limb. What you can then progress that to at a week later, instead of toe tapping, they're actively putting the foot on the step, they're doing a knee to wall, they're coming back, and they're putting their foot on the ground. Then they're doing it with the other side. Those end up transitioning very well into progression to step ups. And that step on or that toe tap, it gives you a good idea of what's an appropriate step up height. So if they can effortlessly toe tap onto an 8 or a 10 or a 12-inch box, I feel much more comfortable with that person introducing step ups at like a 6-inch step, because they've shown the ability to not only access that range of motion, but above and beyond. So what you're asking them to then do from a strength standpoint, it's well within their buffer zone of their available range of motion. It's comparable to having like a knee brace on an individual post-op, and they demonstrate 90 degrees of knee flexion, but you only unlock the brace to 70 or 80. And you give them enough to work with, but you still have that brace kicking in before they would get to their limit of what that tissue can tolerate.
Well, no, that's definitely helpful with those ideas, because I think I've been using multiple methods to gain some knee flexion. But I think always some other ideas are helpful,
Yeah,
especially because I've gotten him kind of late in the game, and so quad strength rise is definitely behind. So
yeah. So other things to think of: is swelling a factor at all in this point?
no,
Perfect.
yeah.
So you don't have to worry about that. What about just general like muscle tone or sensitivity? Like, is he somebody that would be very irritable on a foam roller?
I don't know. I don't think so.
Okay.
I needled his hamstring not too long ago, and I went from 110 to 115. So that
Okay.
was great. But now it's been a couple weeks, I'm stuck at 115.
Okay.
Yeah.
Yeah, that's another thing to think of too, is just from a tissue sensitivity. Oh, it's Corey. You're the CJ that's on there. I was like, who is the CJ that's in our? I was trying to rack my brain of the CJs that we had. Yeah, so that's another thing to keep in mind of brainstorming. What are all of the things in theory that could limit knee flexion? Is it swelling? Is it pain? Is it true soft tissue limitations in regard? Think about like immobilized and having a contracture that we need to actually do long duration, low load stretching. Is it just a novelty of movement and we have fear avoidance, or we have protective guarding? And then the other thing, when you get to higher ranges of range of motion, don't be afraid to look posterior knee. Dig around proximal gastroc, dig around hamstring, think about popliteus, especially if there's somebody that has a hard time with weight bearing, because think of all the co-contraction that has to happen within that knee joint when you're in a weight bearing position, or if it's the achievement of active range of motion as well. And sometimes you hit a limit where those muscles haven't been in that position yet and they don't really know how to respond to it. And just giving them any type of stimulus sometimes can be beneficial, whether it's through Therax, whether it's through palpation or soft tissue means. Corey, do you have any thoughts as well? I don't know if that's why you chimed in or if you're just trying to get me to quit talking.
Not at all. I was going to say the thing about the other things the knee does as well. So the knee is also rotatory, right? So like looking at tibial rotation, sometimes it's like one, either IR or ER, usually it's IR, but usually one of those two is a little limited, especially if it's limited actively. So you can look active versus passive, but if they can't rotate, they're going to have trouble with those end ranges of extension and flexion. And then the other joints involved. So the other joint on the knee, there is that fibular head, that tib fib joint.
Yeah, he moves pretty well there.
Good.
Yeah.
Because sometimes I've had a couple of people where you're like, either they're hyper mobile. So now we've got to work on ankle eversion to like stabilize that lateral knee. And then all of a sudden, boom, now I can move. It's interesting that you needled hamstrings and they got a little more motion. In other words, why are the hamstrings protecting? Why are they guarding? Hamstrings are rotators of the knee, and they're lateral and medial stabilizers. So if you can kind of track down like what else movement wise might be limited as you're going, throughout the joint, then maybe that's another thing that might contribute to like, gosh, I just need this end range. It might be something hidden in those other movements of the joint as well. Just throwing that out there.
No, that's helpful. Thank you.
Something also to think about, and Corey just kind of brought this to mind, is think about the concept of like reciprocal inhibition as well. So maybe doing some degree of isometric, either to the agonist or the antagonist. And they're far enough out where this could be a wall sit, or this could be some degree of like manually resisted hamstring activity, and see if almost retraining them what a maximal or high effort muscle contraction feels like. You're going to get some degree of a refractory period after that where you may be able to sneak in a little bit of range of motion as well. Or sometimes I always refer to muscles, they get that you have the on or the off switch, and sometimes it gets like stuck in the middle and the lights are just flickering and they don't really know where they're at. Sometimes you just have to show them and teach them what all the way on feels like so that they can see what that other end of the spectrum is as well.
Yeah, I've done a little bit of some isometric work. I just did it with him last session. So I'm hoping to hopefully integrate that a little bit more. But no, this has definitely been helpful to kind of talk through, because he's definitely been an interesting case.
When will he return to the orthopedic? So when is the next follow-up? And because of the CRPS complication, has the orthopedic voiced any definitive changes in regards to expectations with returning to run or strength activities? I guess what does communication look like there?
So he actually just saw the surgeon this past week, and I kind of had relayed to him to kind of check in on that with his surgeon. And at least either my patient couldn't communicate it or he got nothing from a surgeon, because the surgeon was just like, great, go forth, keep going. I think so. He had originally gotten prescribed gabapentin, which didn't do anything. And then he saw a different surgeon who got him on an antidepressant, which who knows if that's a factor, working, not working, but we're getting along with it. So I think his surgeon was not happy about that. The fact that he saw other opinions. So I think there's some interesting communication going on there. So I haven't gotten a lot on guidelines with return to run or anything. It's more been my directive with the patient of talking to him about expectations in the process and how it looks different just because of what he's kind of gone through.
Cool. Anecdotally speaking, when I have had postoperative patients with CRPS, I have been encouraged by the orthopedics I've worked with to try to stick to the script as much as possible. Part of that just to try to promote consistency, regularity from both the physical and a mental side with regards to the rehab. But just being mindful that CRPS, like we had talked about earlier, is going to play a role just with day-to-day, week-to-week clinical presentation, what you may be able to do acutely in that session, or how that may affect forecasting as well. Talk me through a little bit of what you would like to see this individual do, just from a functional demonstration of strength and movement quality, or if there's any objective tests that you would like to do when you get closer to that return to run decision-making.
Right, so that's actually where I was kind of headed, is return to run. So I usually like to kind of set up a little bit of just a very objective functional goal for them that makes sense. Is I like to see like 10 solid single leg squats to a bench or equal on both limbs that look pretty much equal and feel equal. That's where I like to start before I start even just kind of an intro to return to run in more of that higher level single limb loading. That's usually like my first metric. So like now that I have him doing some squats and loading into a little bit of a reverse lunge, he's getting excited now, right? He's off the crutches finally. He's like 4 months finally like doing this stuff. He's like, I'm ready to go. And I'm like, well, I want to see this before we can talk about that next stage. So that's what I've told him as like kind of a measure.
Cool. So I love where your head's at with that. If we're looking at body weight competency, think about what are some of the other muscle groups that are going to be involved with return to running. And in reality, it's the entire lower limb. So easy things that you can do. And I always tell people testing can be extremely formal or it can be relatively informal as well. Part of that has to do with the context of the setting that you're in. Part of that has to do with the resources you have at your disposal. Do we have a biodex and a 100-yard turf field and a full weight room? Or do we have a 500 square foot treatment space with a plinth, a couple of hand weights, and whatever the other PT is not using right now? I've been in both environments, so I know that they both have their pros, they both have their cons, but guess what? I've had to return athletes to running in both environments with drastically different setups. So a kind of quick and easy body weight routine that you can go through, 25 heel raises, single leg heel raises. And then that way you've got something looking at gastrocsoleus complex. I like the single leg squat, and there's a variety of ways that you can do that. You can do just like the single leg squat to a bench or plyo box, or just something that you can quantify the height. Remember, a test is anything that you can quantify and that you can repeat and measure against itself in the future. So some tests are going to have definitive literature and research that support them and that it will match up with what you are trying to do with your patient population. Not every injury and patient demographic is going to have a research test that supports it. So sometimes you're just going to have to use clinical judgment of, does this make sense, and measure the qualities that are necessary to do this feature activity. So we can do a single leg squat. That'll be more of like a knee extension, quad dominant activity. And then I'm a big fan of seeing them do 10 single leg elevated bridges as well. So use that same bench they did their squats, lie on their back, have one heel on the bench. Can they do 10 bridges on each side? That would be an extremely quick, dirty, easy thing to do with somebody. Other ways that you can test quad strength, single leg wall sit. So if we want to look at something where the difference between a single leg wall sit and a single leg squat, we have isometric versus isotonic, or static versus dynamic. But the benefit of being isometric with the single leg wall sit, how much are your hamstrings and your glutes going to help with you do a wall sit? Not a heck of a lot. It's a vertical trunk position. It's a 90-degree knee angle, flat foot. It is largely a knee extension dominant activity. Whereas if somebody struggles with a single leg squat, we may not have a great idea. Is this quad deficit from a strength standpoint? Is this balance issue? Is this just coordination and movement quality? You can pick up some of that by how they perform the contralateral limb. But pairing that single leg wall sit with your current single leg squat assessment, I think that'll give you two really good assessments that both have a knee extension emphasis on them, and will let you start to see patterns. And if they struggle with both, then you clue in, we probably need to do a little bit more quad strength with this individual. Are you familiar with an anterior step down test?
Yes. Yep.
Perfect.
Mhm.